Hello. That's right, people. It is bite-sized learning again. So I'm your host, Dr. Mike Sevilla, president of the Ohio Academy of Family Physicians, still just for another few weeks. We have a great topic coming up tonight, but first I do want to just a couple announcements just to remind you of some great other programming that's coming up for OAFP. Coming up later this week, there's going to be a webinar from ABFM for residents and new to practice physicians. Q&A for residents. It is June 15th from 7 to 8:30, and it's virtual. And there's more information at ohioafp.org. Great information, and there's even some archive webinars on there too for you to check out. Secondly, if you were not able to catch live the challenging race-based medicine in practice program, it is a webinar, and it is a webinar on demand. And I've talked about this before on this program here. It was a great program, but you can now purchase it and check it out and watch it. And I encourage you to do that. And of course, our final announcement is, of course, yes, we have merch. On behalf of the foundation of the Ohio Academy of Family Physicians, you can get a lot of cool stuff. You can get masks, you can get shirts, you can get all kinds of stuff. And of course, the proceeds go to the foundation of the Ohio Academy of Family Physicians, where we sponsor student programming promoting, of course, family medicine. So before I bring on our great guest for tonight's program, I just want to set up kind of our conversation because, I get a lot of messages from all of you out there. That's right, you. And some of you who are not physicians who enjoy the conversation, thank you for doing that. Or people who are almost physicians, that's right, medical students, I'm looking at you too. So tonight's topic has to do with something that's called practice management. And what does that mean? So that means that not only am I, Mike Sevilla, a family physician, I'm also a small business owner here in Salem, Ohio. And like other business owners, we have to make sure that we have enough funding and cash and all that stuff coming in so we can pay our employees and pay and all that kind of stuff. And it's not something that's really talked about, but it's very important because, I am the business owner, and I'm an owner of a practice that's not owned by anybody else. It's not owned by a hospital. It's not owned by anything else, and it's getting far and fewer between. And why is it? That's beyond the scope of what we're going to talk about tonight. But it's important for business owners like me to have that knowledge of that. And why is that important? It's because there's fewer and fewer of these what we call independent practices out there. And tonight's topic, it has to do with payment for medical services, and it's changing in a good way, and that's going to be part of our discussion here tonight. And as a part of our transparency, our program is sponsored by Adelaide. I'm sorry. And they are sponsoring our program tonight. And our guest coming on, we're talking about all this stuff, is a good friend of mine for a long time. Dr. Kim Yu is going to be talking about a lot of this stuff and educating me and educating a lot of us on a lot of these important topics. So let's bring her on now. So hello, Kim. How are you?
I'm doing great. How are you, Mike? It's so good to be here and with you again, and it's exciting to be talking to you tonight about value-based care.
This is such an important topic, and I know, Kim and I go way back, and she wears many, many hats. But she has already been on Zoom most of the day today, representing the American Academy of Family Physicians at the AMA meeting. So thank you for doing that, and thank you for joining us tonight. This is a very important topic. I know you do have a slide deck that we're going to go through, but do you have some opening comments kind of on this topic and the importance of this topic before we dive into your slides?
Yeah, I do. It's been really interesting the past year and a half. I worked worked now with Aledade for over a year and a half, and joined because of many of our family doctor friends who are part of Aledade. And I was like, what is this? What is this company? What are they doing with value-based care? And seeing that I was a solo private practice doc for over 10 years when I was in Michigan. And I know how hard it is to be a business owner. And I wanted to see what is it that we can do to help practices thrive in practice. And so it's really exciting to see the things that we are able to do in value-based care and the success stories that are coming out because of the work that physicians are doing in value-based care around the country.
Great. So when we pull up your slides, and what we're going to do is what we've done previously on this program is, our presenter is going to be talking, but I'm going to be interjecting and asking questions that you are thinking out there on Facebook and YouTube. So go ahead there, Kim. We can go ahead and get started.
That sounds great. So we're going to be talking about transitioning to value-based care in the future after CPC Plus. And so many of the practices in Ohio and in other states have participated in some forms of value-based care and some may not. And so we're going to really look at all the different value payment models that are out there, what's coming in the future, and we can transition to the next slide. Introductions, I already told you, I'm a regional medical director. Hey, Mike, with Aledade, and work with practices around the country, and with my practices back in Michigan in value-based care. And as I said, it was a solo private practice doc for over 10 years, and really have been working a lot with the AAFP, as Mike said, on the AAFP delegation to the AMA, and was a president for the Michigan Academy of Family Physicians, and have known Mike through the AAFP for many, many years. So have a lot of respect and love for our academy, and I want to thank the Ohio Academy for inviting me to talk to you today. Mike, we've gone back way back. Is it 20 years? Do I dare say that? I think it is at least 20 plus years. So
yes. And as we start out, one of the really cool things just about family medicine in general is that, you and I have, we've seen kind of medicine change. We've seen our friends and colleagues, in different settings and doing different things in family medicine, and you have done different things in family medicine and moved, and that's just the beauty of family medicine. And I'm glad that we can continue our conversation tonight on such an important topic.
Definitely. So we'll move on to some objectives. We're going to learn the different models, and we're going to learn some tips for transitioning to value-based care and maximizing success to thrive in practice, and then look at some insights into the future. Next slide. Little background on Aledade, so you know a little bit about us. It was founded in 2014 with a simple but radical idea that we will only succeed when our partner practices succeed. And we serve as that strategic partner that really helps independent primary care physicians navigate the world of value-based care while supporting them in physician-led ACOs. And we envision a more efficient healthcare delivery system by keeping patients and physicians at the center of all that we do. So you can see how we're in 33 states with over 800 independent practices, over 100 community health centers, over 8,000 physicians now, and working with many different value-based payer partnerships, multi-payer, with many different EHRs. And it's really exciting to be able to provide that boots on the ground workflow and technical support to practices, and really help them with a lot of the work in value-based care. So let's go on to some value-based care payment models. You can see here there's 4 different main categories of value-based payment, where the first one is fee-for-service with no link to quality, all the way down to population-based payments. And so in between 1 to 4, you can see fee-for-service linked to quality and value. And those are the types of programs like the pay for performance that you may be familiar with, or pay for reporting, and you get rewards for performance rewards and penalties if you don't meet your measures. And then you may have alternative payment models that are built on a fee-for-service architecture, where you have what's called APMs, right? Alternative payment models, where you can get upside gain sharing and also possibility for downside risk. And I'm going to talk a little bit more about what upside and downside mean in the next few slides. CMS really has, as I said, those 4 categories. Our current state is what you see on the left-hand side of the slide, where that category 1 main fee for service, right, is much larger than all the other bubbles. But the future state where CMS wants us to go, and where a lot of payers and insurance companies wants us to go, is more on the value-based care side. And you can see it's shrinking, the fee-for-service shrinking all the way down, and much larger category 2, 3s, and 4s, all the way to the population-based payments in future years. Next
and would
slide.
you say kind of like that's what's starting to happen now, Kim? Like some of that future state really is kind of starting to happen right now.
Right now it's happening. And here you can see, actually, this is from 2019 from the Healthcare Payment Learning and Action Network, where they show you the breakdown of like the category 1 all the way to 4, with 40% in the category 1 fee for service, category 2 with fee for service linked to quality and value being about 25%. And in category 3 with the alternative payment models, 30% of practices do alternative payment models, right? And then 5% are in this population-based payment. And so you can see that actually the shift here is more towards that green, where you can see up to 14.5% are in this combination of both upside and downside risk. And we'll talk more a little bit about what that means too. When you think about risk, insurance, performance risk is not the same as insurance risk. Insurance companies are regulated by state laws and have required financial reserves to take on that insurance risk. And so we don't want to take on insurance risk. Do you want insurance risk, Mike?
Not really.
No, right? But we can manage service utilization, right? And the quality of the services for our patients. But those contracts that really look at performance risk, not insurance risk, performance risk, should be tailored to market dynamics, socio-demographic factors, whether the physician is ready or not to be involved in that, and the availability of resources. Because it's hard to do this work if you don't have resources to be able to do this work. This is what I call the risk continuum. So when you move from limited risk on the left-hand side all the way to complete risk on the right-hand side. So as I said earlier, those performance-based programs are on the left-hand side where there's very little risk. If you do what's right, then you get a little bit extra. All the way through to the other side, and where we talk about capitation, where many of you are familiar with capitation, where you get a fixed fee every month for your managed care patients. The program I really want to highlight the most and go into detail a little bit more is the Medicare Shared Savings Program called the MSSP program, or the Accountable Care Programs. And those are those ACOs, right? Accountable Care Organizations. And the reason why I focus on that one is because it's the largest, most successful in terms of cost savings impact for Medicare, and it offers the greatest economic upside for physicians. So that's the most important thing to remember about when you go from down here risks to all the way up to pay for success, the outcomes-based payments. Having a Medicare Shared Savings Program really has helped physicians get more benefits and financially for their practices.
Now, right in the middle of the slide there, it says level of financial risk, and it's kind of going in an upscale there.
Mm-hmm.
So what does that actually mean?
Okay, if I'm going to tell you a little bit more in 2 slides.
Okay.
Is that okay?
That's cool.
So we'll talk a lot about that in this slide. So we'll talk about risk in this slide. And so you can see this is our Medicare Shared Savings Program, which is this voluntary program that you can join, right? Which encourages doctors to get together and form these ACOs, or accountable care organizations. And they really help provide coordinated quality care for all your Medicare patients. And so the MSSP program really requires your ACOs to promote evidence-based medicine and to really report internally on quality and cost metrics and everything across the line. So you work together to have teamwork to be able to provide the improvement in quality and being able to streamline the processes so that you can share in the financial savings that ensue. In this sort of pathway from basic A all the way to enhanced, think of this as like a 1 year going across each line. Now, there are some practices that are very advanced in value-based care who may go in at a basic E level or, enhanced. But most people start at basic A. And in basic A, there is just what's called upside risk. And you get shared savings of 40%. Well, what's shared savings? Well, the shared savings are with ACO improvement in care and decreased costs. A share of the savings goes to the ACO. So if you show CMS that you actually take care of your patients a certain way and save money, right, you get a share of those savings. And in basic A, you get 40%. Okay. It's just an upside. There's no downside risk. There's no paying back. Okay. So upside really means that, the participants, the people in the program, really are able to share in the savings if their services make care delivery more efficient. Downside risk is where you could potentially lose revenue if your services exceed the financial clinical thresholds. There's something called a benchmark, okay? And it's pretty complicated to describe, but if I just say, if a certain, Medicare knows that certain patients cost a certain amount of money, right? So,
Right.
when you go to a certain place to buy something, it's usually around that price, right? But you go to somewhere else and it suddenly costs a lot more, then you're like, hold on a minute, that's not a savings, right? I want to go somewhere where it may be lower, right? And so if you're able to show Medicare that your patients actually cost less than your benchmark regionally, then that's where you actually have a savings, okay? And the problem is that sometimes if you don't reach that benchmark, if you cost more than everyone else, then that's where you may have to pay back. And there's that downside risk. Okay. And so the issue with all of these programs, you can see the downside is nothing in basic A. There's no risk. In basic C, D, it's 30%, and E, it's 30%. And in enhanced, it's 40%. But there's a risk cap. And a risk cap just means that you don't pay the 30%. You pay only the 2 to 4% or the 8%. And you might say to me, I don't want to pay anything.
Right.
I don't, right?
Right.
And so that's why, in Allidated, we actually cover the risk cap. So that's what's really important is that different programs have different risk caps, like that they will decide on, like whether they're going to cover that or not. So you need to know on your contracts, who's covering the risk cap, what's happening with that, what is the downside, what's the upside. And you can see as you move along from year to year, the more risk you take, the greater the upside. So it goes from 40% to 75%, which is a tremendous amount of difference, for a practice in terms of how much money that you can get for your practice.
So like you said before, you can take more risk, but then you do everything and you meet your benchmarks, then you get the reward for taking the risk.
Exactly.
And that's the progression as you're seeing on the screen here.
That's exactly what you're seeing right now. Obviously the upside risk models are the safer option, but downside risk arrangements really offer more potential for cost savings for physicians and are really a key part of the road to true value-based care. So we're seeing more and more, plans and payers really try and move people to more risk because they're able to actually, fine-tune the amount of savings that are available to practices.
Is the goal for all practices to get to enhanced, or some people just can't get there?
Well, there may be some practices that need to stay in basic A, but, it depends on where you're at. Our goal is to get everybody to enhance because we want our practices to have the enhanced upside of 75%, right?
Mm-hmm.
That's a big difference from 40%. That's almost double. the amount of money that you would get.
Gotcha.
And as you progress from year to year, your improvements in ACO work actually exponentially goes up. Like, I mean, the ability to be able to do ACO work is easier because you know what you need to do, you know what metrics to follow. We have all the workflow processes in place, and we see year on year success. And we've seen that even this past year, from 2019 to 2020, we're seeing the successes of our practices that really solidify how this model of moving from one track to another has really empowered and helped our practices really thrive in value-based care. So just a little bit about, ACOs in general, accountable care organizations. They really are all about the work that we as family physicians do, focusing on preventive medicine, getting patients the right care at the right time in the right place, and preventing that duplicative care and unnecessary care. So, that population health management, coordinated care, quality performance, it's all stuff that we as family docs do already. So, being part of an ACO that can help you in terms of getting some of the workflows and information and data that you might need to be able to do this even more streamlined can be very helpful. We know that this is a slide that's really fascinating, actually, about Medicare's experience operating the Medicare Shared Savings Program over the past 8 years. And this slide shows you the experience, the performance experience difference between low revenue, which are actually physician-led ACOs, okay, compared to high revenue or hospital-led ACOs. So you can see that physician-led independent primary care docs that are doing ACO work actually outperform hospital-led ACOs, and they drive by far more shared savings compared to hospital-led ACOs. And really what drives most of that difference are the incentive alignment problems, if you think about it, between hospital business models and the fundamental objective of reducing total cost of care. That's why, we focus exclusively on building those relationships with primary care physician-led ACOs, and why our savings results are significant and predictable. And we've had a lot of growth, from physicians, not only in independent practice, but also, those who are in hospital-led ACOs realizing that they could actually potentially get much better performance from being in a physician-led ACO. What about CPC Plus? So we know that, CPC Plus, you could have done CPC Plus with an ACO, and there are some practices that are still doing it up to this year. It will be concluding. It started in 2017. Round one began in January of 2017. It's a 5-year multi-payer program. And really, CPC Plus is a program that provides practices upfront revenue, that really to provide comprehensive care, right? And there are 3 types of payments. So there's a prospective paid payment that you get up front, a management payment. You get a performance-based payment, and then you get a retrospective payment that looks back at stuff. So you can do both CPC Plus and an ACO. The issue is that CPC Plus actually goes away at the end of this year. And so for a lot of practices that have been doing this, they've actually been part of what's, an advanced alternative payment model. And so they've been able to get a 5% bump in their Medicare payments. And that's going away at the end of this year. So a lot of practices are actually thinking right now, well, what am I going to do? What's next for us? A lot of CPC Plus practices, if they're not already in ACO, should really do ACO work, because you can, especially if you go into an enhanced or, one of the track E, you can still get that 5% extra bump. Okay. So that's something really important to know, is that you can get that additional for you if you decide to do that. The other thing is that ACO reporting is identical under the MIP system and the APM system. And like we do all MIP reporting for our practices. So a lot of practices who are doing CPC Plus, they're having to do it all on their own. It's a lot of burden to have to do a lot of MIPS reporting on their own. And so that's the main thing that I would say about CPC Plus is really think about joining an ACO and thinking about the next program, which, on the next slide we can go to. This is primary care first. This is CMS's, next thing on the block, which is starting. And many of you may have signed up for this. The deadline's passed now to be able to sign up for primary care first. It's another advanced alternative payment model that also allows people to get, participants are able to get a bonus. And so their total primary care payment is made up of a population-based payment. So they get a monthly capitation type payment, right? That's based on the practice risk group bucket. Does that sound complicated?
It does a little bit, yeah. A risk bucket.
Bucket. Okay, so like have you heard of hierarchical condition category codes, like HCC codes, risk
Oh
codes?
yeah. I'm familiar with that.
So you need to know what your practice's HCC risk score is, right? And so the PCF payment is actually based on that flat fee that you will get based on that score. And what we've noticed is that most practices don't have a high enough score to be able to get a high enough monthly capitation. The capitation starts at like $28, I think, per month. And then when you see a patient, instead of your regular E&M visit, you'll get $40, around $40. $48.82 for a face-to-face encounter. So if you've got an E&M visit like 99213, how much do you get for that, Mike? Probably around $90 to $100 or something, right?
Okay.
So, but instead of that, you will get $40, and then you'll get your monthly fee, whatever it is, which could be $28 all the way to $175. Now, there's going to be very few people who are going to get that $175 per month, right? Because you're going to have a very high risk bucket. And most people that we've looked at don't fall in that bucket at all. They're in the first bucket of $28. So there's a lot of interesting caveats to this. There's different tracks. There's a general one and the seriously ill population one where you have to do stuff with a hospice and palliative care, ensure that you have that capability in your practice. So I think PCF is a possibility, but only for practices that really are advanced in doing value-based care work, honestly, and only if you're going to be doing it with a partner that is able to give you the information that you need to be able to do primary care first work. So when you think of the quality reporting that we do for our practices, in primary care first, a lot of that you have to do yourself. So there's some benefits, if you're going to do primary care first to doing ACO work, because they both feed, like in some ways you're doing one for the other, right? You're doing the work already. So it's important to really consider different alternative payment models wisely. And we actually have ways to be able to help practices get a report of what would it mean to my practice if I did PCF? What would it mean if I did, like CPC Plus, all of these different things? What would it mean if I joined an ACO? We actually go through that with practices so that they get that information ahead of time. They don't have to worry about their finances. Can move on. The third one I want to talk about is direct contracting. And it really is very complex. Like when I say complex attempt at delivery system reform, this is as deep as it gets. Like this thing is like complex. Okay. Trust me on this. It's so complex. Anyway, it's where you get payment is both a capitation and a partially capitated population-based payment. And you actually have to direct contract, not with CMS, but with an entity. So are these things called DCEs or direct contracting entities. And the entity takes your money from Medicare and decides how much money to give to you. So it's not Medicare that decides how much to give to you, but it is the direct contracting entity that decides how much they're going to give you. And so I have real concerns about that because there's, there's a possibility, depending on the company that you pick, that they may have great like resources and things that they may say that they are able to provide. However, it's a very new program. And it's almost like a pilot in many ways. And for now, we recommend practices to stick with what has been around for a while, which is the Medicare Shared Savings Program and the value-based care tracks that are available right now, rather than direct contracting. And that's why we have that little QR code. You can scan that QR code to really get an informed decision about direct contracting and your practice. And so, yeah, it's complex, and just the benchmark changes too when you join a direct contracting entity. So I talked about that benchmark. Your regional benchmark will change, so it'll be harder to get savings. So it really is a very complex area, and one that
Are there a lot of entities out there at this point, or is it so new?
There are actually. Yeah, there. I can't remember exactly the number of entities there are out there. I know that's less than 100.
Okay.
And Medicare actually stopped the number of entities that could join. And so that was like a red flag of like, why do they want it to stop if they're saying that this is so great? If it's so great, then we should be, having all these other companies doing this work. But I think that it really, truly is, in many ways, going to be interesting to see how these entities work. Some of these entities have not performed well in shared savings previously, and we can look at the data and go, do I really want that company, or really managing all of my Medicare reimbursement and telling me as an independent primary doc how much they're going to pay me? That's not how if I were a solo private practice doc, I wouldn't want to hedge my bet, because it could change. CMS could decide to change the benchmark. They could decide to change, all these different things within the pilot, and you'll be beholden to that entity, pretty much. So there's a lot of concerns that we have with this.
But the QR code has some more information.
Yeah, QR code has more information. Next slide. So really, I want to talk a little bit about this gap. And in England, I'm originally from England, and we have the tube, and we always say, mind the gap on the tube. You don't want to fall in the gap. But there is this gap, between fee-for-service and value-based payments. And, suddenly all the health insurers and CMS and commercial enterprises need everyone in their networks to change everything. And 1 minute we're told to max out our services, and the next minute we're penalized for overspending and lack of quality control, and we're supposed to jump over this gap to get to value-based payments. And so we know that fee-for-service is on the decline. In 2012, there's about 90% of practices were in fee-for-service, and that went down to 83% in 2016, and it's even lower now. So as we transition to value-based care, we need to figure out this gap. Next slide. Part of understanding the gap is really understanding, the total expenditures, right? And improving measurable health outcomes by managing that, because the new rewards and penalties are geared towards these two goals. But unfortunately, many physicians feel that they don't have the tools and resources to be able to reduce costs. And this is a survey from Deloitte that showed, of family physicians, that showed that 51% of physicians are aware of the cost of treatments. 40% are comfortable discussing the cost of treatments with tests, so less than half of us. It's difficult to know what the cost is of treatments and tests when you select it. You just know it's high, like MRI high, right? My husband paid a lot of money for an MRI that he really needed to have done, and it was shocking, the difference. He actually had an MRI, and then he had a CT. He needed a contrast CT, and the contrast CT cost more because it was done in a hospital. Exactly. And I just wish that we knew those things beforehand, right? Mm-hmm. And so, do you have the tools to be able to make those choices with your patients? so that you can succeed in value-based care. We actually have tools within our Aledade app that actually tell physicians how much the cost is for every test, every visit, every specialist, subspecialist visit, every hospital stay. We actually have the costs in there, so patients and physicians together can see the costs together. Next slide. And the next thing is really focusing on some key things that you can do to really help with, improving cost of care. We know that if you do annual wellness visits, if you do transitional care management, if you do ED follow-up calls, and if you really look at your, we have what's called a daily huddle in our app, where we're able to really accurately help look at the diagnosis suggestions for that patient. If you do all of these things, it can dramatically improve the savings and revenues for patients. So you imagine if you did 7 transitional care visits, right? You can prevent that 1 readmission. Or doing 12 ED follow-up calls, you reduce that ED visit in the future, right? All of these things you're probably doing. But do you have access to resources that tell you who's in the hospital right now? A lot of times, practices won't have that resource, or they may, but it may be late. And then they've already missed that window for the 2-day you need to call within 2 business days to get that transitional care management visit scheduled, right? Mm-hmm. So do you get that information? And we're able to get that information to our practices by the hour. So they're actually able to see when the patient is in the hospital and when they're discharged from the hospital, when they need that annual wellness visit, right? So things like that can be very helpful. Can you hear my dog? He's like running around my feet right now. Sorry about that.
Excited about this.
Yes, I think so. Next slide. What about quality reporting? This is actually really interesting information from the AAFP. And so if you found your practice in the gap and you're feeling like you're nearing the edge of the gap, we want to simplify. One of the strategies is to simplify quality reporting with the right technology. And this is, the report says that 60% of family docs have more than 7 contracts with payers and have to, report. How many do you think you have?
Oh, we've a lot more than that.
A lot more than 7, right?
A lot more than that, yeah.
So that equates to 2.6 hours per week that a physician spends submitting quality measures, 12.5 hours that your staff spend per physician, which equals 758 hours per year per physician spending on quality reporting. Okay. So that's incredible, right? But we know that doing all these measures and everything, it's important because it helps us identify weaknesses and prevents overuse and misuse of healthcare services. But we need to ensure that our practices and our physicians have the resources and to have the right health IT infrastructure in place. So this is when, having a relationship or partnership with someone that is able to give you this information or help you with, quality reporting can be very helpful. I remember trying to do hypertension quality measures. And, I think it was with Blue Cross Blue Shield, and they came back to me and said, this was many years ago when I was in private practice, and they said, you missed it by 1%. You didn't take blood pressures on these 1% of people. I was like, what do you mean? We take blood pressures on everybody that walks through the door. But they didn't tell me that until like 2 weeks before the end of the performance year, right? And so I wasn't able to call those people in. And I actually found out those patients weren't my patients. They weren't attributed to me.
Yeah, exactly.
Wouldn't you like to know who those patients are ahead of time, who are attributed to you, and who needs blood pressures taken?
Yeah.
So it's super important to really be able to get the care that we need for our patients and make sure that your EHR is really integrated and searchable, and that you keep an eye on your EHR dashboards to stay on top of everything. Next slide. Other things, the second strategy that you can do is to really utilize non-financial supports offered by payers. And so a lot of payers now, because of these tying financial incentives to quality, they're recognizing that physicians need access to additional resources. And so whether it be care management support services for your patients with complex care needs, or you may see that they have a physician referral program or a self-referral program for patients, or one that I love, social determinants of health support, whether they have referral programs for food insecurity and non-impact, non-health socioeconomic factors, to resources that the AFP has, like the Neighborhood Navigator or Health Landscape. Looking at those resources can be very helpful too. And then looking at education and trainings like the ones that Ohio Academy is doing, and the ones that the payers may be doing to really help with streamlining claim submissions or quality reporting or, best practices, can be very helpful too. Although, the Ohio one's the best, right?
Exactly.
The best. So the third strategy is change management within your practice, and really ensuring that the operations are designed to support your business goals and in every way, and also your practice needs, right? So having someone that is able to lead the change management process can really empower them to really get the information and resources they need. And that having a well-designed, well-run operation really contributes to everyone's satisfaction, whether it be patients or physicians or well-being of your staff. So breaking down those silos that drive you crazy, building an accessible, practical strategy, eliminating redundant work, reprioritizing and making sure you have the tasks and responsibilities as needed. Like, what do you find is one of the hardest challenges for you in terms of change management and practice workflow? What would you love to see happen for your practice?
It's just balancing the work and then just trying to find ways to make the changes, because you need the time, you need the resources, you need the will to do it, and just running a busy practice. And you sometimes, and this, Kim, it's just trying to get the work done. It's just trying to get the patient work done, and then but just trying to find those efficiencies. It's challenging to change. People, we've done this like this, forever. We don't want to change. We're like, it's not working. Why do you want to keep doing it? But there are all those challenges in workflow. Is we all know that it works when you get there, but it's that change management is just so challenging.
It can be really challenging. I think that one thing that we found really helpful is when you find a workflow that works, stick to it. And we found one thing that I found really interesting is there are some practices when we start working with them, we find out that their workflow, for example, when they're trying to find out who's in the hospital. How do you find out who's in the hospital? Like, you round at the hospital, so But there was one practice where the physicians were rounding. There were 11 physicians in the practice, and they all rounded to the hospital. And the office manager had to go to each person to ask, okay, who was discharged? And it was really hard because this poor office manager was literally running around the practice every day trying to say, okay, who needs to be called now? And so when we're able to provide resources to say, these are the patients, she didn't have to do that anymore. She just cut out at least an hour of her day where she wasn't running around. So finding where you can really help maximize efficiency so that, the people that need to do the work are doing the work and you don't have to be the one running around, that can be super helpful too.
Now, before we leave the slide, what does that QR code do?
Yeah. The QR code is our roadmap for primary care, making the shift to value-based care. And it provides you with more detailed information and guidance about how to implement these processes within your practice. So I really highly encourage you, if you want to look for more information about how do you actually implement some of these processes, you can go to that QR code. On the clinical outcomes front, our results get better and better each year as our ACOs really perform better and better as well, which really translates to more and more shared savings. And you can see here, this is just an example for a 2-physician practice, where the red is actually from Medicare fee-for-service revenue. So that's where you're doing more annual wellness visits because you actually know the patients that need annual wellness visits. You're doing more transitional care management because you actually know who needs that TCM visit, right? And so we see most practices increase in their revenue, their fee-for-service revenue, up to 17, 18, 20% sometimes, compared to their previous year. When they get to year one, because your shared savings actually comes the year after you start, for example, if you started 2022 in January, you get paid October 2023. So you get it the year after, you can see that increase. And so you see PMPY means per member per year, so per patient per year, if you think about it. The fee-for-service revenue in the first year increases by 126, and then the shared savings is 191, and that actually is conservative. It's actually more than that. Many of our practices are getting much more than that. And as you get more payers, like Medicare Advantage, Medicaid, Centene, Anthem, Blue Cross, whatever it might be, Aetna, the more that you have in value-based care, you can actually exponentially increase your savings and revenue for your practice, which can really help transform your economics and really help. A lot of our practices actually said when we gave them the check, it was just so amazing. It really was, because they were like, this meant the world. This meant that I could stay open this year. And that gives me goosebumps, because I know how hard it is to keep in practice and not have to lay off staff. We have so many practices that told us we didn't have to lay off any staff this year. We made it because of what we did in our ACO. And that's a huge, that to me is transformative, and so wonderful to my heart, and why I keep doing what I do. It's exciting. It really is. Next slide. So just in terms of, improved outcomes, it's not just about the money. It really is about improving care for our patients. And we know that when you increase primary care utilization, we're able to increase it. And you think, well, how is that saving money if you're increasing it? We know that the dent and the amount of money that's spent on primary care is like this much, like 7%. So even if we increase it by 20%, that does nothing overall. It's just a very small divot in the amount of total cost of care. But if we're able to decrease ER utilization, as we were, by 14%, or inpatient by 15%, and skilled nursing by 22%, you can see significant savings right there that we're able to do. And that goes back to the practices in shared savings. And then finally, sort of the future of value-based care, because I know, Mike, that you wanted me to touch on this. I really think that there's 4 aspects. One is that it's going to be all patients, all payers. It's not going to just be Medicare. It's going to be Medicare Advantage. It's going to be your Medicaid. It's going to be pediatric patients, maybe OB. It'll be all patients, all payers, because we see the value and the real true beauty of family medicine is that we can do this. We've been doing it already. It's just we need the resources to be able to do it more effectively. So that goes to our number 2, which is population health management and health equity. There are tools out there, population health tools. Many of you may be using them already, and many of you want to use some of them because it will give you data to help manage your patients more easily. If you think of, I want to be able to know which patients went to the hospital the most, went to the ED the most, but maybe had diabetes. Give me a list of those. Previously, it'd be really hard to figure out. You may know because you know your patients well. I know Mrs. Smith, Mr. So-and-so, there's a certain number, right? But it's very hard to know the whole list that you can go through. We're developing pilot programs with continuous glucose monitors that are for those patients that are high utilizers, so that we can really wrap our arms around our patients and take better care of them. And so it really helps us improve care delivery. We can look at social determinants, reduce disparities. It's really exciting. Tech and AI is also another thing that we can do. So using AI, but always remember to be high touch as well as high tech. And then having that team-based care and the partnerships. So really having collaborative relationships, not only with organizations, whether it be someone like Aledade or other organizations, but that you really seek out partners in the community. We've seen with COVID, 40% of practices around the country, according to the Larry Green survey, right, that people are doing. They've been doing more community outreach and working with community partners. I think that value-based care is really going to see a lot more partnerships with hospitals, with urgent cares in your area, your nursing homes, other community organizations, so that together we can develop these collaborative care coordination models that will help improve care. And I know we're near the end of this and I'm way over 30 minutes, but in terms of resources, we wanted to just provide some more QR codes for your free guide, for a comprehensive guide to value-based care. You can reach out to me or, to outreach@aledade.com. But, there is so many benefits to being involved in value-based care and taking those first steps, or whether you're already in CPC Plus and you're very experienced and you want to know your next steps. We really are excited to be able to work with practices in Ohio and around the country, if you're joining us from around the country, to really help you thrive in practice and get what's best for you, what's best for patients, and what's best for your communities. And I like to show my mug. Can you see my mug? Can you see what it says?
Hard to see.
It says service. Do you see it now?
Yeah, I can see it now. Yeah.
We do what is good. I can't read it backwards. We do what is good for doctors, good for patients, and good for society. So that's what we're all about. And I just welcome any questions. Oh, before I forget, our deadline. Okay, there's a deadline. It's really important you know this. Do you know the deadline, Mike?
I don't. Tell me.
So the deadline to join an ACO is actually August 3rd. It's August 3rd. So it's really important that you get discussing, because it takes a lot of, you have to do a lot of things beforehand to really decide if you're going to be part of an ACO. And so you want to reach out before that August 3rd, definitely like as soon as possible. And actually we had the first rounds of deadlines actually ends June 28th to form a new ACO. Is actually June 28th for that, forming the new ACO. But, if you want to actually participate in an ACO, it's August 3rd. So we have a link to that on the deadline information, and also more links that you're able to see, I think, hopefully, that were shared with you as well.
Yeah, so the link is in the comments, and we can also share that out in other ways for that. But yeah, just like you said, Kim, I mean, it's for practices who are interested. I mean, there's a lot of kind of background information, a lot of numbers. I would guess you would need to kind of go into your EMR to try to get some of this information, and I presume it's like an application process, or is you just submit this, or obviously just reach out to you, or
yeah, you reach out to outreach@aledade.com, or you can reach me at kyu@aledade.com, and we get the process started for you. It's super simple, and our outreach specialists are there, ready to help you be able to know if this is the right move for you. And I would say that if you're in an independent practice, and even if you're in a community health center, because we're working with community health centers now, that this is the future. Value-based care is the future. It's not going away. But you have an opportunity to really get benefits and revenue for your practice through shared savings, through MSSP ACO work that you're already doing. You're doing annual wellness visits, transitional care management. You're seeing patients in the hospital, or have partners that do. And you take care of your patients after they come out of the hospital. You're doing the work. Get paid for it. That's what I would say.
Great. Those are great closing thoughts. And yeah, thank you for the QR codes. And I know there's more information out there. So I don't know if you've anything else to add before we kind of close things up. You already kind of had some really good closing thoughts as part of our conversation tonight.
I would really love to hear thoughts from those who are in the community and who may be listening right now, to share with me, if you're not in an ACO, why not? I want to know why. Because for me, it makes sense, but maybe there are other reasons. Maybe it's because you think that you don't have time, or you don't have the resources for it. And I would say and challenge you that there are resources available. We have resources available to help practices get through value-based care and really thrive in practice. None of our practices who are in enhanced or in, the risk-bearing arrangements that we talked about earlier, none of them have had to pay a penny. They've all succeeded. So we want to be able to share that with everyone. Everyone can do well in value-based care. You just need the right partner.
Great. Well, thank you so much, my friend.
Thank you.
It's great to see you.
It's so good to see you. I can't wait to see you in a few months, hopefully, in Kansas City.
Exactly.
And it's going to be really fun.
And we certainly thank Aledade for support of the Ohio Academy of Family Physicians and what we're doing. So that's a great partnership that we have with you. So thank you so much.
Absolutely.
And that closes up our program tonight. So you can always see archives of this wonderful program and past programs at ohioafp.org. So we'll say good night and thank you, Kim. So wave goodbye to everybody. Bye.